Good morning, everybody, and welcome to our webinar on the mounting evidence for topical oxygen therapy. As some of you may know, in the last 6 months or so, a group of us have been working very diligently on looking at the evidence for this, and we have conducted a systematic review, grading, and meta-analysis, and the manuscript is being written up as we speak. So as part of that, even though I can't tell you about the results yet until we submit them and get them published, what I thought I would do is take a dive with you into meta-analysis to give you a sense of some of the stuff that was done during the study, and to also give you a primer at the same time on meta-analysis itself. So the first thing I have to say is I don't have any relevant disclosures. So what we're going to do in this presentation is discuss when is a meta-analysis appropriate and in what circumstances, the different kinds of methods that are available. This problem we call statistical heterogeneity, which can be more than annoying. A lot of common problems and solutions that come up during meta-analysis, and if one is interested, how do you actually get proficient in the subject? So the first thing to understand is you never almost do meta-analysis by itself. Why? Well, there's a lot of different reasons. First of all, you have to do a proper literature search. Can't analyze subjects and studies unless you search for them. The second thing is you have to spend a significant amount of time extracting crucial data information that you're actually going to need for your meta-analysis, including things like outcomes and study lengths. Next, you have to assess the strengths and weaknesses of the studies. And the gold standard these days is GRADE, and several years ago, Cochrane incorporated into its program, and you can read all about it on that link there later at another time. We sometimes think about meta-analysis as simple, and the reason being is when Cochrane got its program called RevMan up and running like 25 years ago, part of the package that came with it is a very simple meta-analysis subprogram. And unfortunately, at that time, it was inordinately easy to use, which means that you could get yourself into serious trouble very quickly. There's a lot of reasons why meta-analysis is actually quite challenging, even though sometimes with point-and-click programs it seems simple. The first thing you have to figure out is whether and how to combine different study designs. This includes outcomes and study lengths. You have to really understand the difference between fixed and random effects. You have to understand the different meta-analytical methods. You have to learn how to deal with statistical heterogeneity, how to measure it, and how to assess it in terms of whether it needs to be figured out or not. You'll have to learn a lot about meta-analytical quirks to get meta-analytical results correct. And finally, you'll have to understand about sensitivity analysis. So why do we do it? So there are three really different reasons for doing it. And the most common one is, and we know this in wound care, a lot of studies are just small. So each individual study often doesn't have convincing evidence by itself. So if you were able to pool all those studies, we might actually improve the precision and learn something. Second thing is you might want to investigate questions that are not actually covered in individual studies. One of the most common things that you might think about is different wound types. So you're looking at an intervention and you want to figure out, does this intervention work equally for all wound types or just one or two? And lastly, it's a method of trying to settle controversy where you have apparently conflicting results, or you want to study a new hypothesis that came up. So for example, one might think about, do interventions in wound care work with smaller or younger wounds, ischemic or non-ischemic wounds, and so forth? You're going to have to do a fair amount of homework for your meta-analysis. You can't combine controlled and uncontrolled studies. What that means essentially is you're going to have to separate out randomized controlled trials from cohort or observational study designs. You can do observational study designs with meta-analysis just like RCTs. They're just not done as frequently because the amount of data and the quality of the data typically isn't as good as RCTs, but you're welcome to do it. Next, you have to figure out what outcomes you're going to use. Complete wound healing is obviously the best and most common one, but it's not the only one. You could think about things like percentage area reduction. You could think about incidence of adverse events. For example, I'm looking at interventions that affect rates of amputation or infection of particular kinds of wounds. Next, you're going to have to figure out what study lengths are you going to use. And typically in RCTs, 12 weeks is a common length, but it's not the only one. You can see 16, 24 weeks or even up to 1 year. And the biggest thing you're going to have to learn here is you cannot combine studies with different study lengths, with one exception. So let us suppose, for example, you had 4 studies of 12 weeks and 1 of 16 weeks. If in the 16-week study you had 12-week outcomes, then you could combine them. But if it doesn't have that, you can't do that. Next, you're going to have to figure out what wounds you're going to study. All types of chronic wounds, one particular subtype, venous leg ulcers, diabetic foot ulcers, or do you want to study all different kinds of wounds and eventually do a subgroup analysis by wound type? Next, you're going to have to think about population characteristics. Are you interested in just what's out there, or are you interested in certain size of wounds, whether wounds are ischemic or not, older or younger wounds, severe wounds, and things like that? So before you start your meta-analysis, as part of your homework, you will need to think about, should I develop inclusion or exclusion criteria, and what should those be? And as an alternative to that process, you could think about, maybe what I really want to do is subgroup analysis, or this thing we call meta-regression, which we'll talk about towards the end. And finally, think about what kinds of quality studies do you want to include, your level of risk. So in Cochrane risk of bias analysis, there are 3 different flavors to that: low, some, and high risk. In theory, it would be nice to have just low risk studies. In practice, that almost never happens. So be sure in your overall homework, when you come up with your plan for meta-analysis, to have a plan B if you have very few or almost no low risk studies. So let's begin by talking about what are fixed effects and random effects models. Fixed effects models basically assume that the estimates come from the underlying intervention effect, and they're all roughly the same. Random effects assume that the studies are estimating different intervention effects. They're all related, but they're all a little bit different. In other words, they're a little more heterogeneous. And the way mathematically we actually combine studies in meta-analysis is to use something called a model weight. In other words, how much does each study actually contribute percentage-wise to the overall pooling of the results? And in random effects and fixed effects models, that algorithm which calculates the model weights is done differently. And so which approach we should use, fixed or random effects, depends mostly, not entirely, but mostly on this term statistical heterogeneity. When you start doing meta-analysis, there are a number of plots that you can do, a number of graphics and so forth, and the most basic of this is called the forest plot. And if you can see my pointer there, I want to go through the various different parts of the typical forest plot. Graphically, they'll look a little bit different in the same programs, but they still have the same things. So on the bottom, you have your scale, and this one is done in odds ratio, and if you're on this side, it says it favors standard of care or whatever your control group is, and this is the intervention group. This is a log scale. You don't have to have it, but it's just done in this case. These are your studies on the y-axis, and this is your total fixed effects. The first thing you'll notice, there's this vertical bar that is marked above the 1. This is what we call the zero effect line. So if you end up with studies over here, and it favors standard of care, clearly something went wrong. If you've got a lot over here, that means the intervention is doing better. And for each individual study, and there's 1, 2, 3, 4 in this, you'll see there's two things. There's a width, and that width represents the 95% confidence interval of whatever the difference is between the two groups that you're measuring. And the next, you have these little boxes. This is the size of the study. So bigger boxes mean more subjects or more participants are in the study. And the next thing at the bottom there is to look at this diamond effect. The diamond represents the pooled effect, whereas the squares just represent the individual studies. And the other part about the diamond effect is its position. So the center of the diamond in this particular example, you can see, is just slightly left of 1, meaning in this particular, and it's a fictitious example, there's not likely to be much of an effect. These are some common patterns of forest plots. The top left one here is the one you really like to see. There's not a huge amount of difference, and there's 5 studies in this meta-analysis, and they're all looking pretty similar. And the diamond pool is well over into one side, and we're presuming it's the interfection. So you don't see that very often. Quite common, you will see something out of whack, like an odd man out. And in this case, where my pointer is, you can see this one's out of whack. And if you look at this one, the bottom left, you can see there's a big one that's out of whack here, and there's some issues going on here. In this case, this is a nice one because the diamond is well free of the 1 bar, so it's going to be statistically significant. Over here, you can see the pooled diamond is sitting on the 1 bar, so it's not going to be statistically significant. And the issue really also has to do with heterogeneity, which we're going to cover in bits. In other words, when you see these kind of odd patterns with odd men out, that's almost certainly going to give you heterogeneity. Here's another one here where the heterogeneity is probably not that bad, but you can see if I look at the diamond, it's just covering the 1 bar vertical there. So this is going to be non-significant too. Another very part of meta-analysis, regardless of what program you have, is the summary data. And this is just 2 related examples. So you'll have a bunch of studies, you'll have intervention and control data, and in this case I've chosen odds ratio, but there will be different forms that we can choose and we'll talk about. So in this case it could be complete wound healing. This is the number that healed in this particular study, 13 out of 20, 13 out of 15, and so forth. There's the odds ratio for each study, and these are your 95% confidence intervals. Don't worry about the Z values. And over here are the contributions to a fixed effects model and a random effects model. And you'll see in this particular example, they're the same. This one on the bottom, they're different because the numbers are slightly different because I tweaked them. And here are your p-values. In this particular, and again, it's a fictitious example, the results are statistically significant. But in this particular example, regardless of whether you used a fixed effects or a random effects model, they are not. So heterogeneity we could think of is this issue of when studies vary hugely in terms of their outcomes of intervention versus control groups. And typically it's measured by something called the Q statistic, which comes from the Cochrane's Q test, which is in turn based on chi-square. So if you look at this little box here, here's the Q value. These are degrees of freedom. Don't worry about that. There's your significance level. And then we have this amazing thing that was invented about 12, 15 years ago called the I Squared Statistic. This is a scale which incorporates that Q statistic, and it runs from 0 to 100%. So in this one, you can see it's about 74%, and there's your 95% confidence interval. So although we can quantify heterogeneity, there isn't a magic number or a gold standard that says, hey, you get to this number, you automatically have a problem. It's really about judgment. So in addressing whether you have to deal with heterogeneity or not, we take some things into effect. If you have, and you decide you have significant heterogeneity, one has to use a random effects model instead of a fixed effects. That's one of the most common ways of dealing with it, but at the same time, one also wants to try to understand a little bit is, how do we get heterogeneity in the first place? Remember when I showed you one of those early studies where there was an odd man out? If it had significant weight, that's almost certainly one strategy to find out. So take out the offender. Does the heterogeneity lower or go away? That's almost certainly the issue. Maybe there are some other data that you can use where you can group studies and figure it out that way. But that said, don't make this a fishing expedition. And one of the things I always say is, when you start your homework for a meta-analysis, you have to develop a plan. In your plan, if you say, if I find heterogeneity in my meta-analysis, how am I going to deal with it? And then just write out some bullets, line out a pathway. Don't go down a rabbit hole, because the chances are, unless you really know what you're doing, you may come up with a spurious explanation. So in extreme cases, when you get a lot of heterogeneity, some people say, just don't do the meta-analysis, and that's certainly always an option. And another option I will always tell you lots of times is ask a statistician. If you ever get in a bind or you don't understand something or you're not sure, go find a statistician to get an opinion, or see if he or she will help you out. There are an awful lot of plots you can get with meta-analysis. In Cochrane, the red man will give you just one or two different ones, but in the major statistical programs, there are about 7 or 8 different plots. But a common one is this thing called the funnel plot. And what it does is it measures the intervention in terms of odds ratio or relative risk, as here. Here's your 1 bar. It's a log scale, 10, 0.1. This is standard error on the y-axis, which is a measure of precision. So what you're doing is comparing precision in studies versus effect size. And this is, again, a fictitious plot, but one of the things I want to show you in this is, like, as my studies tend to get smaller, and generally the rule is bigger studies will nearly always give you better precision. So they will get towards, but never achieve, standard error of 0. So these will be bigger studies typically. These will be smaller ones. But you can see in this example, it's a little bit disturbing, is bigger studies show much less of effect than the smaller ones. That's actually not an uncommon finding in meta-analysis, is bigger studies usually are more useful. Smaller studies have way less precision. And so part of the investigation of meta-analysis is to look at the effects of bigger versus smaller studies. Another one, which you can't find in Cochrane, but most other statistical programs will give you, these what's called Lab A plots, and they come in different flavors. But the idea is basically to plot an event rate in the intervention group versus a control group. There are a lot of different things you can get out of this. One of the things is you want to identify strange studies. In other words, results that have vastly different results from other studies. Maybe you have 3 or 4 different groups, and maybe it's just one particular group in a study that's causing an issue. You can investigate that. Quite commonly, we'll look at trends in size of studies versus effects. So in this particular plot, you can see that's a bigger study. It's got a bigger circle than this one. So these are bigger studies, these are smaller studies. And we're looking at the size of the studies and the overall studies and effects. So you are basically looking at control group risk here versus treatment group risk. And you can see there is not a consistent relationship. I mean, we can draw, and the program did it for me here. It made a linear regression, and these are the 95% confidence intervals. But one of the things it's telling us is that treatment group risk varies according to control group risk. So although in most simpler meta-analysis, a lot of people just skip all these steps, there is actually a wealth of data that you can actually extract when you're doing meta-analysis that can give you a lot of insight, particularly when you have a lot of studies that will tell you about what's going on. Another problem we come across, particularly in wound care, is missing outcomes. Happens for a lot of reasons, but we need to do sensitivity analysis. In other words, let's imagine all those people that lost to follow-up, they died, we took them out, we withdrew them and so forth, or some bad events happened. What might have happened instead? Unfortunately, in wound care, most of the Cochrane reviews do it very badly. They come up with these worst and best case scenario analyses, which are totally unrealistic. In most drug trials, what we tend to do is use something called the jump to reference approach. It can get very sophisticated. We can actually do incredibly sophisticated regression imputation techniques. In meta-analysis, it's much harder to do that, so we want something simpler. So in fact, when we did our Tier 2 meta-analysis project, what I actually did is looked at two different things. First of all, I assumed that when we withdrew patients because they had some kind of adverse event, it was unlikely that these wounds would heal, so we scored them as not healed. But basically, we took the rest of the people who had all kinds of different reasons, and we imputed a healing rate based on the standard of care, and we also applied that to the intervention. So it's one particular way of doing it. Nobody's really done any serious studies in wound care to guide us. So our own institution is starting a project to determine the best methodology to use for sensitivity analysis, and it's probably going to take 6 or 9 months to get that done. What types of analysis can you do? There are 4 commonly used ones. In dichotomous, Mantel-Haenszel, Peto, and 2 flavors of inverse variance. We usually do the Mantel-Haenszel for fixed effects. Peto is for rare events like 1 in 100 or actually rarer, so you're not going to use that very often. And the Durst-Ammonian and Laird inverse variance is used for random effects. And a couple of different ones for doing continuous outcomes, mean and standardized difference. And I like the SND better. There are a couple of issues that you have to worry about. And again, in Cochrane, this is skipped over. Skewed data. One example of this is percentage error reduction. If you've ever looked at plots or graphs of PARs, you can see quite often you get skewed distributions, you get bimodal distributions. So PAR turns out to be a really serious problem child to analyze in terms of meta-analysis. We also have a companion analysis that you can do called meta-regression. So any of you who've read studies of RCTs in wound care, you can see quite commonly we adjust for the primary endpoint. If you do complete wound healing, we'll do a logistic regression, so on like that. So you can think of this is a combination of traditional regression in a meta-analytical context. So what that means is each study only contributes one set of data. So you could think of it as maybe just outcomes, some study characteristics, size of study, what kind of wounds are in there, were there particular strange things, is it a long study, short study? So in other words, there's almost like 3 or 4 characteristics that you will include in that data set. It's an useful alternative to doing subgroup analysis. And sometimes it's actually very helpful to run before you actually decide on doing meta analysis, because you might find 1 or 2 key study attributes that are actually going to affect the meta-analysis, and that's going to guide your subgrouping. Well, here's the big problem. In order to do meta-regression really properly, you need at least 10 to 15 studies. So unfortunately, in wound care, it's rare to get that number of studies in a meta-regression, so it doesn't get done very often. So we talked about RevMan. It's fairly easy to use, in other words, user-friendly. It's free. But here's the problem. There's not a lot of what I would call documentation that goes with a lot of other serious statistical programs that explains exactly what it's doing, all the different options, what they tend to do. There's a lot of stuff in the web that you can read about it, but if you just plunge into it like it's a plug and play program, you can start making serious mistakes very quickly. And in fact, just as an aside, a few years ago, I had a long run-in with editor of a very well-known wound care journal where they published a paper in which meta-analysis was done, but the authors had actually mistaken the heterogeneity results, p-values, for the actual fixed effects model. It was patently wrong. Eventually, their own in-house statistician said it was right. So this is not uncommon. Even in wound care journals, you'll find meta-analyses that are wrong, which is one reason why I say is if you're going to get into this, learn the subject well. What programs should you use? Are there any other options besides RevMan? Well, I like MegCalc. It's got some really nice graphics. You can export them. It's relatively cheap. I think for a single license, it's around about $150, $160. You'll have to learn a little bit of coding, but you don't have to be a statistician. If you want to have all the available options, all the plots and so on, and you want to do those things, you are going to have to use either R or one of the major statistical programs. And then almost certainly you're going to have a statistician do it, unless you're one of those few researchers who's done a lot of statistics. And so in terms of where to go from here, there are 2 or 3 different places I would suggest you go. There's this nice little article, it's published about 20 years ago, but it's still very valid, and it talks about how meta-analysis is neither simple nor easy to do, but it's done in such a way that for most researchers or even practitioners or clinicians who don't have that kind of background, explains all these concepts fairly easily. There's also Cochrane, Chapter 10, which talks about meta-analysis and goes into in depth in some of the things that we've talked about. And I would say that's another go-to place. At least read that through once if you want to get a more full and perhaps bigger breadth training on meta-analysis. And finally, there's this article came out a couple of years ago. If you really want to understand what meta-analysis is doing, both mathematically, all the different pitfalls, some of which we've just covered here, then I would suggest you use that article. But basically, I would only tackle that during the day. This is not night reading. So let's summarize some of the things that we've learned about meta-analysis. So meta-analysis should never be done by itself. You always want to do it in the context of a systematic review, and most preferentially in terms of grade. Meta-analysis is not easy. I mean, it looks easy and it isn't. So do your homework, make sure that you've got all the bases covered and you have a plan. Meta-analysis is not about chasing p-values, and I would say some people think that's all it's about. I want to get a statistically significant meta-analysis done. Really, it's not about that. A well-conducted meta-analysis can give you a huge amount of additional insight into lots of different studies. So that is something that you always want to bear in mind. And finally, and I can't say this enough, if you're in doubt about something, if you're unsure, find a statistician. Thank you for your attention, and good hunting with your meta-analysis.
Thank you, Marissa. That was really outstanding. I'm going to go ahead and put my PowerPoint up. And I will say it has been an amazing education working with Marissa over the last year doing the meta-analysis on topical oxygen. And I'm guilty of being one of those individuals that said, oh, this is easy. But boy, once you get into it and you're into all the steps and grade, you realize that there's a lot to learn. It's a tremendous exercise. And I really suggest that you're going to be publishing and working in wound care, that you really need to get to understand this. and work with it. It is a great exercise, tremendous learning. I've learned more in the last year than I've learned in a long time when it comes to studying meta-analysis. I'm going to speak now about some of the process that is going into our current meta-analysis that Marissa and I and others, many others actually, are working on, in that is looking at topical oxygen therapy and its effectiveness. Fortunately, we have enough information that we can perform a meta-analysis in this topic. I don't have any relevant financial interest. I don't have any stock in any topical oxygen. I've done research for topical oxygen companies, so I guess that's a disclosure in itself. This was supported by EO2. The learning objectives, I think we've gone over that already, but I think from my perspective, I think it's important that you understand the basis of meta-analysis and what we're going through to get the highest level of evidence. Remember, there's an evidence-based pyramid, and we want to be at the top of that pyramid. And I have to tell you, for too long, the wound care community has not been at the pinnacle of the evidence-based pyramid. So we're working on it, and it's progressing, and it's really exciting to see. So topical oxygen, just briefly, how does it work? It's not hyperbaric. It's something very different, although they both use the same element. It's antimicrobial, it increases energy production, and it promotes epithelialization. So the antimicrobial effect is important. Neutrophils and other leukocytes, white blood cells, they kill. They kill by using oxygen. They concentrate free oxygen radicals in this phagosome, and then they bring bacteria in there, and that's how they kill it. Oxygen is a highly reactive element, and when you pull off an electron and make it a reactive oxygen species, it becomes incredibly reactive, and single cell organisms like bacteria cannot tolerate the presence of free oxygen radicals. And it's one of the main ways that our immune system functions. Without this, we would not have a very good innate immune system. So when we look at chronic wounds and you look at bacteria, there is this colonization phase. We're probably going to rename this because I don't think colonization may be the right word. And then there's a transition. And then finally you get to this polymicrobial, both planktonic and biofilm-based bacteria. So, and the nature of the microbiome changes during that time as we go from as we progress. One of the things about topical oxygen that we're beginning to see now in a publication that's just coming out, I think it's slotted for this month, is how topical oxygen has been able to change the microbiome. What's the mechanism of this? Well, the mechanism is what I just mentioned. It really is that oxygen increases our immune ability, the ability of the neutrophils to kill with free oxygen radicals. And so this is the model that we've come up with that says, look, I think we can push this wound backwards. And this is just from the paper that's coming out this month, just showing that there's clear change in the types of bacteria, the microbiome. And this is something that we've just begun to study a little bit more carefully. And looking at this, fortunately, we have fluorescent imaging now, and we're able to study this bacterial loads in a very simple fashion. Number two mechanism is the production of energy. Mitochondria, I'm not a cell biologist or a mitochondriologist, but we know that mitochondria utilize oxygen in order to function. This is cytochrome C oxidase. It's an enzyme on the surface of the mitochondrium, and the mitochondrium produces energy, ATP, for the cell. And how does it get the energy? How does it create the electricity for that energy? It pumps hydrogen ions across the membrane. So inside's negative. It's electricity, if you will. My son, the physicist, says that's not exactly right, but I think it's close enough for us biologists. So in order to make this process work, you need oxygen. The more oxygen you have, the better this process works. And so if you look at animal studies that have been done in a low oxygen environment, the mitochondria produce small amounts of energy, but in normoxic environments, they produce more. And if you make it hyperoxic, either with topical oxygen or with hyperbaric oxygen, they'll produce even more energy. Antimicrobial and in addition to that, increased energy. And then accelerated wound closure. We know that epithelial cells in particular are highly responsive to oxygen. And there's been some animal studies and some human studies looking at percent error reduction. Marissa mentioned PAR as one of the things we look at when we're doing studies and now doing meta-analyses. And we know that oxygen therapy also is important in driving epithelialization. So we have these three mechanisms now. We have the antimicrobial effects, which make the neutrophils kill better, and also macrophages as well. Any of the leukocytes. A high oxygen environment is a better environment. And in the case of many topical oxygen types, you're using continuous diffusion, so there's lots of oxygen being diffused into the wound. All right, so this is just an example of a topical oxygen case where you have a venous ulcer that needs. Actually, if you look closely at that, we've done great compression. Patient has good objective measure of their vascular status. It's nice, it's granulating. I just got to get it to epithelialize now. And this is where topical oxygen played a very nice role, and we were able to continue compression, use topical oxygen device, and get epithelialization. And I think this when you're thinking, where does this topical oxygen fit? I think that this is an area where you may want to use it. I'm going to put another shout out for another manuscript that's coming out in the near future. There was a preview of it in last month's Journal of Wound Care. And later this year, we'll have the guidance for the use of topical oxygen coming out. We had a number of key opinion leaders were involved in that consensus, folks that have used this technology quite a bit, and we put together some guidance that'll have some nice charts for you to look at and use. And so look for that coming out as well. That'll also be in the Journal of Wound Care. And so look for those publications. I think they're going to be important. So one's coming out in wounds, I think later this month. That's the microbiome paper. Then their consensus will come out later this month. And of course, the meta-analysis that Marissa was just mentioning is hopefully out, knock on wood, in a journal by the end of the year, at least online by the end of the year or the first quarter of 2022. A lot of publications on topical oxygen. There's a rising there's a rising boat, if you will, of manuscripts coming out on topical oxygen. All right, this is just another one of my case series. Epidermal cells love oxygen, and this is a case of a diabetic foot ulcer and the use of oxygen therapy, and you can see that it does promote it. Now, this is not from one of our clinical studies. This is obviously something we had done earlier. And it was before actually the latest two clinical trials were completed. All right, so this is a couple cases from our clinical trial, this is a randomized controlled clinical trial looking at the use of topical oxygen in chronic diabetic foot ulcers. All of these patients had to have diabetic foot ulcers for more than 4 weeks or more, and in addition, during that 4 weeks, they could not have healed by 40%. And then we had a run-in period. First, we had a historical run-in period in which, for 2 weeks, they could have any therapy prescribed by the clinician, and they could not have healed by 20%. And then during the second 2 weeks, they got very aggressive basic wound care, aggressive debridement, total contact casting for offloading, reduction in bacterial burden, and obviously moist wound healing to control any maceration or any dryness in the wound. So very aggressive basic wound care. And if they healed by 40% in that 4 weeks, or even 20% in the 2 weeks of aggressive basic wound care, they were out of the trial. Those are the rapid healers. Don't want those. I don't want those patients in our clinical trials. So they would drop out. And you know, the nice thing about this is that when we went to Medicare with this trial, we said these are your patients, because these patients would all meet the national coverage determination or local coverage determination for an advanced wound care modality. No healing or no appreciable healing in a 4-week time frame. In addition to that, I'll just add this in here now, 50% of the patients, actually more than 50% when we got to final enrollment. In the clinical trial we just finished looking at one of the diffusion oxygen modalities, those patients had to we had more than half the patients were 65 years and older. So we have focused on this, and we've got actually 3 very good clinical trials. One of the clinical trials as well was double blind, and one of the 3 was a double blind trial where we had a placebo involved as well as an active oxygen treatment. I wish we could have done both of them double blind. It just didn't work out from a logistical sense. So we have look at the quality of those clinical trials. And I tell you, when we did the meta-analysis and looked at all 3 of the major clinical trials that have been done recently in topical oxygen, they really stand out as having been well-conducted clinical trials. And you can look up those 3 references. They're readily available. If you want to send me an email at the end of this, I'd be more than happy to provide it. We're also, to add more publications, we're also coming out with a publication on clinical trial design. I really like this design that we've adopted in these recent diabetic foot ulcer clinical trials. And Dr. Driver and I are going to be coming out with a paper on, what does a clinical trial look like if you're looking for FDA and approval and Medicare approval, and what should it look like? And I will tell you right off the bat that it really needs to look like you've done an NCD or an LCD. Like it needs to look like their patients. Now I'm going to tell you something I'm really guilty of. In the early days, we took everybody with the diabetic foot ulcer and we threw them in the trial. This is 10 years ago. This is how we thought clinical trials should be conducted. And that's really changed. So if you're looking back at those old clinical trials and say, well, you guys in wound care, you don't know what you're doing. Well, maybe we didn't back then, but that's really changed a lot since then. We have got good clinical trial design, and the meta-analysis that Dr. Carter was talking about really demonstrates that very nicely, that our new clinical trial designs will give us high grade scores on these modalities. I mentioned this, that this is from our leadership conference in New Orleans this year, one of our first in-person ones, thank God. It was nice to actually get together, although I love the advantage of these virtual conferences, but it was nice to actually see people. This was published in the Journal of Wound Care, where we did guidelines on how topical oxygen should be employed. All right, so I want to go through that consensus document with you now because we have a little bit of time left. And this is, again, it was published as an editorial and will be published in a formal peer-reviewed publication later this year. And I've got some graphic arts people working on the nice flow diagrams, because I did the other ones on Excel and I'm not that good at it. So, but let's go ahead and go through what the consensus document said. So the following workup, what should we do? Before we use topical oxygen, we should assess limb perfusion. Just about everyone agree with that. Assess bacterial load, nutritional assessment, a lot of agreement on that. And so this is a Delphi consensus. And for a Delphi consensus, you need to have agreement of 70 to 75%. Different groups will set that agreement level. Typical at 70%. We were able to achieve that with 2 rounds of the Delphi. Debris edema management, and then offloading, and look at the consensus on offloading. The big consensus here: objective measure of vascular status, offloading for your diabetic ulcers. Next, topical oxygen should be considered in the following circumstances: when there's delayed wound healing, as in our clinical trial, 40% healing and the lack of 40% healing in 4 weeks, that's when you're going to use topical oxygen therapy. 100% consensus in that group. The Delphi group was the picture I just showed you, all the key opinion leaders that we invited to that meeting. There was 38 showed up, and then there were additional individuals that couldn't make it who participated in the Delphi as well. But everyone agreed. Delayed wound healing is when we should be looking to use topical oxygen therapy. And then failure of prior therapies. That's similar to 1 and 2 are pretty similar, but a high consensus. And then there was some consensus on ischemic ulcers, although I think that the vascular surgeons in the group wanted to be sure that we had put that parenthetical portion in here, and that is that after all efforts have been exhausted to revascularize the affected area. So you don't want to just throw topical oxygen on there and say, oh, if it doesn't work, I'll refer the patient for vascular intervention. Don't do that. That's really not what I'm saying here. This is ischemic ulcers that cannot be have any further revascularization, or maybe they're not a candidate for revascularization at all. All right. What wound types are likely to benefit? There was a strong consensus on diabetic foot ulcers, but I will tell you that has largely to do with the evidence. And we, like I said, 3 randomized controlled trials done by 3 different industry partners, all showing benefit and a strong benefit. And in fact, in the most recently published one, not only did it meet the per protocol, but the intent to treat population. And that's really a strong recommendation for topical oxygen and DFU. Venous leg ulcers, a little less consensus, but still statistically positive, and the same with ischemic ulcers, where we find consensus at 77%. But I've promised all of our vascular colleagues that I would put this caveat in there after all attempts at revascularization have been exhausted. Frequency and duration were the next portions and the questions in the Delphi. And number 4, patients receiving topical oxygen should be seen weekly. And this is has actually got one of the lowest consensus we had in anything. Some people were saying twice a week. I see my patients in topical oxygen weekly. I think that's, because we actually put it under total contact casting or under a fixed ankle walker. So I'm not changing it. That's easy to do. All the devices can accommodate that are available. And then number 5, how long should patients receive topical oxygen? We said that they should be reassessed every 4 weeks and continue topical oxygen as long as the wound is improving, and this would be by 40%. We should see a 40% improvement over 4 weeks, 30 to 40% over 4 weeks, and the consensus is fairly strong on this at 84%. All right, this is the non-graphic specialist version from the editorial, and it just goes over an algorithm of, you have a chronic wounds heal less than 40% in 4 weeks, refractory to other therapies, assess the patient for topical oxygen, as we said, and then once you're using topical oxygen, reevaluate wound healing at 4 weeks, and if it's improving, continue topical oxygen. If not, let's reassess the patient. What else? Maybe there's too much bacteria there. Maybe there's too many proteases or something else going on that topical oxygen is not addressing. There is no magic bullet, right? We need multimodality therapy, and we need to have lots of arrows in our quiver if you're going to be a wound care specialist. All right. One thing I want to talk about briefly is that topical oxygen is not a threat to hyperbaric oxygen. I have hyperbaric oxygen therapy at dozens of centers across the United States. I don't feel that topical oxygen is a competitor. Topical oxygen is generally locally and it's applied over a broader range of time. It's clinical trials or in Wagner 1 and 2, hyperbaric clinical trials in Wagner 3. You have a clear delineation between what type of diabetic patients, for example, are going to be topical and which ones are going to be hyperbaric. Also, we have rural communities that just don't have hyperbaric oxygen and patients don't have access to it, so we can use topical oxygen in that. These technologies are complementary, not competitive. Complementary, not competitive. I'll repeat myself. So I think understand the mechanism is important when you're trying to decide. Hyperbaric oxygen therapy is a very potent therapy in these very difficult Wagner 3 diabetic foot ulcers, and we don't use Wagner 2. We don't use hyperbaric oxygen for Wagner 2 ulcers. It's really reserved for our 3s. So when you're looking for something to use on your Wagner's 1s and 2s, topical oxygen therapy is a good option to consider. All right, so I'm going to pause here, and we're gonna turn it over for questions. Just to go in summary, Dr. Carter has outlined what is a tremendous amount of very serious work in developing a meta-analysis. We have developed a meta-analysis for the use of topical oxygen. It's in progress. Dr. Carter made me promise that we wouldn't divulge any of the results thus far, but I think everyone will be very pleased when it's eventually published later this year or early next. We went over a number of clinical trials that have been conducted. Again, 3 trials conducted by 3 different industry partners, all of which showed a the benefits of topical oxygen therapy in the treatment of diabetic foot ulcerations and strong. One of those trials was double blind. And another one of the trials really focused on hard to heal patients in a Medicare population. So really strong evidence. And I think you'll see that when you look at the meta-analysis and you look at the grade criteria for these various trials. We're also going to address older trials that have been done in the past that may not have been quite as positive. But the trial designs, as I said previously, very different trial design and very different technology. So, I think, this is a technology that's improving, like all technology. And so I don't think we can look back on older technology and say, oh, well, topical oxygen didn't work 15 years ago. Well, it's a totally different ball game at the present time. So, at this point, I think, Alan, I think we can turn it over for questions.
Absolutely. We have good 10 or 15 minutes for questions. And a few questions have been introduced by actually some of your colleagues that are well known to you. I won't identify them by name. But the first question is for Marissa. It starts off, excellent, Marissa. With so few good wound studies, heterogeneity becomes a problem. Is there really a minimum number of studies you'd consider in order to do a proper MA?
Yeah, that's a very good question. I don't know that statisticians really have actually addressed that. It's not so much is there a minimum number, it's a question of what is a good number that is representative of the problem you're studying. I mean, I've actually published meta-analyses on 2 or 3 studies, and it's simply because, we were looking at 1 or 2, this is not necessarily in wound care, but we're looking at 1 or 2 very specific studies that are very close. So I would say there isn't a minimum number. Another thing you might run into is, let's suppose, and we ran into this in the study we've been doing the last 6 months. Maybe you only have 1 or 2 low-risk studies as quantified by Cochrane risk of bias, and you've got a bunch of other high-risk or some risk studies. So in that case, what do you do? And, it's not an easy answer. It's not like Cochrane or any of those guys or great people say, well, if this happens, you do this. If this happens, you do this. There is all about the judgment. And so, for example, if you have 1 low-risk study and 3 some-risk or high-risk studies, what I tend to do is, and it's written in my plan, is say, well, I'm going to do them all. But I'm going to write about the results and codify it and guide you a little bit as to what those things mean.
Okay, thank you for that response. Another question from the same individual, this one for Dr. Serena, and I again won't mention his name, but will mention his initials, RF. In case
we knew he was going to be on the phone. Yeah, on the call.
I thought that might resonate. Great talk, Thomas. Can you comment on any putative difference between CDO delivery versus pressurized delivery in terms of its physiological effects?
I don't think there's any good evidence that the difference in delivery makes a difference. I just don't. What we've seen in the trials is that when you look at risk, Dr. Carter was just talking about risk. When we compared the trials, they were very comparable. So I think when I look at this, I think when you look at a diffusion versus versus a topical application in with the system that RF is talking about, I don't think there's any difference. I think probably it'll be up to the individual clinicians on what they want to use, what's practical for their environment as well. So but I don't see Marissa, I think you'd agree with that. We didn't see much different between those, although it wasn't something we lumped them all together, but we didn't really do analysis of the differences. But I don't think you'd find it.
No, I would say I could tell you that when we did the analysis and we looked at the studies, one of the things, and Dr. Serena's just said this, is the most three recent were very different to the one that was done about 2015, 2014, and might have been published a little bit later. And in part, there's been a revolution, I think, in the structure and integrity of CDO devices. So that's one of the reasons. But the other thing is we've learned a lot, as Dr. Serena said, in the last 10, 12 years, how to do better trials. I mean, long time ago when I met Tom, oh gosh, it was probably about 2011, I decided, between all of us, we really needed to do things differently. And so you are seeing better trials in part because I and a lot of others have decided we need to do better in wound care design.
Yeah, no, and we've been forced by Medicare in a lot of cases to do better. I was tired of going to get my butt handed to me in a Medicare meeting because they ripped my trials to shreds. So we worked together with Marissa and Vicky Driver and RF and others to really up our game.
So we've been talking a great deal about statistics and research. We do have a question about the basic administration of topical oxygen. Could you take a few minutes and review how the device is applied, for what periods of time, and how you prescribe it?
So it's, the prescription, I think, get the guidelines, get your guidelines for that, for the prescriptive use of the device. There's a number of different devices. There's one that comes in as a dressing that you can prescribe as a dressing and works very nicely. And there's others that are just topical oxygen, and then another where you give it intermittently, and that's what RF was talking about. So there's a number of different devices. I think you look and see what works best for you and your setting. You also need to look at reimbursement. We're actively working on garnering reimbursement for this. It's not reimbursed across the U.S., so you want to find out. If that's true in your area or not. And it's very easy. I mean, all these systems are easy to use and incredibly easy to use. I know when we did the clinical trials and we've used, I've used. When we look at those 3 clinical trials, we've used all those products, and they're very, very easy to use. In compared to some other modalities.
Okay, and you've really covered this comparison, but I think this individual is just looking for a conclusion. Do you now believe that the data on topical oxygen for DFUs is more robust than that for hyperbaric oxygen, standard hyperbaric oxygen? Would you call the data more robust and convincing?
I think, so topical oxygen has an advantage over the HBO manuscripts. The HBO manuscripts, look at the first 3 were done in the 90s. And then later ones were done, before 2010. Now there's been some subsequent to that, but for the most part, the major trials were done before we knew what the heck we were doing. And that includes me. So I think topical oxygen has the advantage in that the trial design has matured. As Marissa was just mentioning, it's really matured a lot. So I have to give it a bit of an advantage on the research side, simply because HBO does not have a trial that can match the trial designs we've had for the recent topical agents.
Yeah, I think that's exactly right. I mean, some of the earliest trials date back to the 80s, and so you can see over the decades, if you look at systematic reviews that have come out, they started off in the 90s. So yeah, this is really good stuff. It works. And as more trials were added, I think the level of evidence became smaller and smaller until finally everybody said, I'm not even sure this is actually working for diabetic foot ulcers in terms of healing. And there were a lot of reasons for that probably we can't go into. but some of it has to do with the fact that even after all the work that's been done, it's very hard to know who's going to respond to HBO. I think in terms of TOT, it's much easier. I mean, if somebody asked me, what do you think the level of evidence is for TOT versus HBO, I would have to personally say at this point, it's a little bit higher for TOT. And I was more of a skeptic, I suppose, because I got involved in a CAC 2 or 3 years ago on TOT. And at that point, some of these trials we'd just been talking about hadn't come out. So I think there is a little bit more evidence. And the other thing is, in terms of real world evidence, Dr. Margolis put the monkey in the wrench around about 7 or 8 years ago with his huge observational study that was flawed. This is HBO.
Oh, kudos to the investigators for Topical for achieving that. It's remarkable. We have a question, one more question, a practical one about Medicare coverage. Could either of you address that for topical oxygen?
I missed the question, Alan.
Medicare coverage, is it covered by Medicare?
No, not at the current time. There are some Medicaid and private insurers that are paying for it, but it's not. We're working right now. That's part of a Medicare hasn't seen these studies yet, so or the meta-analysis. Well, meta-analysis we're not done yet, but they haven't seen this quite yet. So once these are all packaged nicely, then we're going to go ahead and try to get coverage for it. I really hope we have coverage for it by next year. One last thing on topical and hyperbaric. I don't think they're competitors. I use both. And Wagner 3 complex ulcers, that's the diabetic ulcers, those go to HBO. And then I think as we get Medicare approval, we use it more and more. Topical oxygen will go into the 1s and 2s. And then we have to get rid of Wagner at some point. We need as Marissa said, we need a much better way to tell who's going to benefit from topical, HBO, other modalities than the Wagner classification.
All right, well, doctors, thank you very much for your excellent balanced presentation today. We appreciate it. I think we learned a lot.
My pleasure.